Welcome back. Let's wrap up our discussions about personality disorders with some case studies. Let's look at a few real world scenarios that illustrate how personality disorders might present during EMS calls. These examples are composites, but they should feel familiar or plausible. Case 1: Borderline personality disorder. You're dispatched to a young female who reportedly cut herself. On arrival, the 25-year-old patient has a few superficial wrist lacerations. She's sobbing and saying, "I want to die. My boyfriend left me." As you begin to assess her, she suddenly shifts. She screams at you and your partner, "Just get out, you don't care about me." But minutes later, as you prepare to comply with her wishes, she panics and grabs your arm, pleading, "Please don't leave me alone." This kind of roller coaster of emotions, desperation, anger, fear of abandonment, is very indicative of BPD. It's a challenging scene. She's physically not badly hurt, but emotionally in extreme distress. EMS response. The crew needs to remain patient and calm. One strategy is to maintain a reassuring presence. "We're here to help, we won't leave you," while also setting gentle limits. For instance, if she's screaming or trying to push you, give her a moment but stay where she can see you. Self harm patients also require a careful suicide risk assessment and transport for psychiatric evaluation, even if the injuries are minor, due to the high suicide risk with BPD. Case 2: Antisocial personality disorder. A 30-year-old male was involved in a bar fight. Police are on scene when you arrive. The patient has obvious cuts and bruises, possibly a broken hand, but he's agitated and combative. He's cursing at everyone, including you. "Get the bleep away from me. I don't need an ambulance." He's pacing and has an aggressive posture, maybe even taking swings at the air. This behavior, hostility, refusal of help, and lack of concern for his own injuries could fit with antisocial PD, especially if you learn he has a history of similar incidents. He doesn't care about the law or his safety, and he shows no remorse for the fight. EMS response. Scene safety is paramount. Likely, law enforcement will need to secure him if he requires treatment. For EMS, the best approach is not to engage with any verbal insults and keep instructions very direct and calm. If he refuses care and has decision making capacity, which can be questionable if intoxicated, you might not be able to treat or transport, but ensure police are aware of the medical issues. If he's a danger, he may need to be restrained per protocol for everyone's safety. Always have an exit route and don't turn your back on an actively hostile patient. Many services have protocols for handling violent patients, including possible chemical restraint if necessary for patient and provider safety. Documentation here would need to be very thorough. More on that later. Case 3: Dependent personality disorder. You likely know patients like this 50-year-old male. He calls 911 frequently, reporting issues like chest pain or difficulty breathing that turn out to be relatively minor or unfounded upon exam. Today, he says he has a mild headache and dizziness. On arrival, he is extremely anxious, clutching a list of medications and doctor's notes. Vital signs are mostly normal. He insists on going to the hospital again. During transport, he constantly asks, "You'll stay with me the whole time, right? I'm so scared. What if something happens?" He may not explicitly have a diagnosed dependent PD, but his behavior fits. He believes he can't manage anything without medical professionals present. He's overly reliant on EMS for comfort and decisions. EMS response. While it can be frustrating to handle repeat callers, maintain empathy. This patient's fear is very real to him. Provide reassurance, "We'll take good care of you," and consider involving a social worker or community paramedicine follow-up for frequent non-emergent callers. Also, check that no acute condition is present this time. Don't dismiss complaints outright. If this pattern is known, you might gently suggest alternatives. Have you talked to your doctor about a plan for when you feel this way so you don't have to call 911 every time? But do this with compassion, not judgment. The goal is to help him feel supported while also steering him toward more appropriate resources. These scenarios show just a few ways personality disorders can appear in our work. Each requires a slightly different approach, which brings us to the challenges and strategies in dealing with these patients. Working with patients who have personality disorders can introduce several challenges beyond the typical medical issues. Key challenges include communication barriers. These patients may not communicate in the expected way. For example, a paranoid individual might misinterpret your words, "Why are you really taking my blood pressure? Are you trying to drug me?" making it hard to establish trust. A borderline patient might say hurtful things or become suddenly tearful, which can throw you off. Essentially, their perception of the situation can be skewed by their disorder, leading to mistrust or disproportionate reactions. This makes the normal rapport building more difficult. Compliance issues. It's not uncommon for PD patients to refuse treatment or transport even when they need it. A paranoid or narcissistic patient might flat out refuse because they don't want to relinquish control or they doubt your competence. Borderline patients might initially agree, but then abruptly resist care if their mood shifts. Others may not follow instructions, like an antisocial personality may simply not care about your request to stay still for a blood pressure reading, or an OCPD patient might refuse a necessary intervention because it's not being done the right way according to them. Noncompliance can jeopardize patient outcomes and frustrate providers. Manipulation or boundary testing. Some personality disorders, especially in cluster B, can involve manipulative behaviors. Splitting is a classic example with borderline patients. They might idolize one crew member, "You're the only one who understands me," while devaluing another. "That other EMT is horrible. I only want to talk to you." This can create tension within the team if you're not aware of it. One provider might be seen as the good guy, the other, the bad guy. Narcissistic and antisocial patients might try to push boundaries or play staff against each other to get what they want, like pain meds or simply control of the situation. Histrionic or dependent patients may excessively demand attention, calling you back into the room repeatedly or constantly diverting conversation to unrelated dramas. Recognize these behaviors not as personal attacks, but as symptoms of their disorder. It's crucial to set clear boundaries, politely but firmly, and ensure the team stays on the same page. Safety concerns. We must always consider scene safety, and certain personality disorder behaviors can increase risk. Borderline patients with active self harm or suicidal behavior pose a danger to themselves and can be unpredictable, one moment calm, next moment trying to jump off the stretcher. Antisocial personalities or any highly agitated individual could present a violence risk to EMS. Paranoid patients might have weapons if they fear threats, or they could suddenly lash out if they think you're harming them. Even a narcissistic person, if extremely insulted, might become aggressive. Always be alert to the potential for escalation. If a patient has a known history of violent behavior, or you pick up cues of possible violence, employ your safety protocols. Maintain a safe distance, have an exit route, call for police backup early if needed, and never hesitate to involve additional resources. Recognizing these challenges in real time allows you to adjust your approach. Thank you for going on this journey with me. With your training and empathy, you can make a big difference even in these tough calls. Stay safe and professional out there.